We'll go ahead and get started. Welcome everyone to part 2 of our Ebb and Flow webinar series. My name is Sammy Burton. I will be your moderator for today's presentation. I am a pharmacist by background, and I am a medical science liaison with the Baxter Medical Affairs Infusion Systems team. If you missed part 1 of this series, which covered strategies prior to dispensing, the recording is posted on our Medical Affairs News to Infuse website, and there will be a QR code for that on one of the last slides after Jenny presents. But today we're doing part 2, which is strategies for minimizing flow rate variability with syringe pumps at initiation and during infusions. And our speaker today is Jenny White. She is a nurse by background and also a medical science liaison on the Baxter Medical Affairs Infusion Systems team. Prior to joining Baxter, Jenny has multiple years of experience in NICU and in pediatric critical care flight nursing. So she has a wealth of information and will be sharing some great insights with everyone today. Jenny, if you want to go to the next slide, just a few housekeeping items before we get started. So you'll see on the screen here the attendee interface. So this should be similar to what you're seeing on your screen. You can submit questions using the Q&A feature. So you just click that Q&A icon on the top toolbar, and then a Q&A window will open and you can type your questions into that field. You can type them at any point during the presentation. I'll be monitoring the Q&A, and then Jenny will start to answer and answer as many of those as she can once we get to the Q&A portion after her presentation. And then next slide, Jenny. Last housekeeping item. We will have a participation survey at the end of the presentation. There'll be a QR code. If you have a few minutes to complete that, it would be greatly appreciated. That helps us to improve for future webinars and also choose relevant topics that you all would like to hear. And with that, I will hand it over to Jenny to get started.
Hi everyone, my name is Jenny White. I am a RN, BSN, Principal Medical Liaison for Infusion Therapies and Technologies at Baxter Healthcare Corporation. For financial disclosures, I am a speaker and an employee of Baxter Health. I have no other financial disclosures. Learning objectives for today's presentation will be, I'm going to be listing the factors that can cause a variation in flow rates with syringe pumps, discuss strategies to promote flow rate continuity with syringe pumps when preparing and administering infusions via syringes. Back in 2016, the FDA did have a communication on flow rate continuity issues with syringe pumps, and it bears highlighting again, even though it is a decade later, because the information is still relevant but not widely known. And we'll talk more on that shortly. I want to start off this with a fun fact. So the first syringe pump was created back in 1658 by Christopher Wren. It was called a syringe driver. Here you'll see a photo of the first photographed syringe pump, which is very interesting to see how it looks now versus how it did back in the day. Some background for large volume and syringe pumps. So large volume pumps, they'll deliver fluids, medications, and blood via IV or epidural routes. They're more accurate than manually adjusting rates with a gravity administration. Their flow rate ranges are 0.1 to 1500 mLs an hour, with accuracies for plus or minus 5 to 10%. They are peristaltic or cassette pumping mechanisms, and they're primarily used in adult and pediatric patients. Syringe pumps will deliver fluids, medication, blood, and enteral nutrition via IV, epidural, or enteral routes. They accurately deliver fluids and medications with small volumes, less than 60 mLs, at low flow rates, 0.5 to 10 mLs an hour, with flow rate ranges of 0.01 to 1200 mLs an hour. Syringe pumps have an accuracy of plus or minus 2 to 5%, which is syringe dependent. They're stepper motor and lead screw mechanisms. They're primarily used with anesthesia, neonatal intensive care patients, pediatric patients, as well as fluid-restricted adult patients in oncology. Here's a question for everyone. Have you ever started an infusion on your syringe pump and noted that you're titrating up faster than expected, and then had to titrate back to your starting rate quickly? Now let's talk about startup delays. Startup delays are influenced by mechanical slack, stiction, and compliance. Mechanical slack is caused by any type of gap in the syringe pump system. For example, if the syringe is not properly loaded, there could be a gap between the top of the syringe plunger and the plunger driver head. So when the pump is turned on, it will take some time for the plunger driver head to come in contact with that plunger. This is why it's so important that the syringe is properly loaded into the syringe pump and is in contact with all the areas of the pump that it should be. It can take some time for the gears to fully engage at the low flow rates and to begin running smoothly. Priming from the pump can help engage the gears more quickly and decrease that mechanical slack. This is why when you see a delay in effectiveness in your critical drip would be due to that mechanical slack. Also, when a pump is started, it initially has to push against the downstream pressures and sensing your sensor disc, your back check valves, or your filters until the pressure is equalized. So any accessory device that's added, the pump is going to have to work against. Stiction is the sticking and friction between a syringe plunger and the barrel. You have probably felt this yourself when you've pulled back on a syringe plunger, and you probably noticed that larger syringes have more stiction than the smaller syringes. For compliance, compliance is syringe and administration set expansion and contraction due to the pressure. Compliance is related to the elasticity of the syringe and the compatibility and the compressibility of the rubber stopper. Plastic syringes can swell when pressure is exerted inside the syringe. You may not be able to visualize this, but it can occur to a degree that affects the flow rate. You can see in the photo of the plunger with the rubber stopper from a larger syringe. If you've ever removed this plunger from a large syringe and pressed the rubber stopper, you've noticed that it is compressible. This is because the pocket of air is in the stopper. Rubber stoppers in larger syringes are considered more compliant, meaning they contract and expand more, because the pocket of air within the stopper must be compressed before the stopper can begin to push fluid forward into the patient. For smaller syringes, they have less compliant and are more rigid stoppers, so when you can push the fluid forward sooner to that patient. Not the traditional definition of the word compliant, but you may be thinking in this case that more compliant is considered quote unquote bad and less compliant is considered good when it comes to flow rate continuity. Syringe pumps must overcome all of these forces and compress the rubber stopper before the delivery of fluid can occur. Your startup time depends on flow rate and syringe brand and size. Large syringes and low flow rates are going to cause longer delays when you're starting infusions or changing the rate of an infusion. So again, the theme here of large syringes and low flow rates causing potential flow rate accuracy issues. So let's take a closer look at syringe-related factors. The image on this slide demonstrates how the syringe pump works, so you can understand its pumping mechanism can affect the flow rate continuity, keeping in mind that this mechanism applies to most syringe pumps. Syringe pumps have a stepper motor and a gearbox. The motor and the gears turn a lead screw, which causes the nut to move along the lead screw. Think of this like a nut and bolt. If you turn the bolt, the nut will move along the bolt. In a syringe pump, nut is attached to a pusher block that holds the plunger together. When the lead screw turns, the nut and pusher block will move forward, which propels the plunger forward. Moving the plunger forward pushes the fluid out of the syringe into the tubing and to the patient. At low programmed fluid rates, it will take a while for the gears to engage, and that lead screw is going to turn slowly. and it will therefore take more time for the fluids or medication to reach your patient, especially if the tubing has not been primed on the pump. At higher programmed rates, the engagement occurs much quicker. Let's take a look at how this affects flow continuity. Another question is, in your current practice, do you utilize the prime feature on the pump after you've manually primed your tubing? When you program a syringe pump at an infusion of 1 ml an hour, for example, what you can expect to see is to the table here, you'll see that purple line at a steady 1 ml an hour. But because the syringe pump mechanism and the characteristics of syringes and low flow rate, what you'll actually see is a period of time before the infusion reaches the desired rate, shown here by the red actual rate line. This is referred to as your startup delay. How long the delay takes is dependent on the rate. Low rates cause longer delays. The syringe size, large syringes, especially at low flow rates, will have longer delays. Whether or not the nurse has primed the pump, using that prime feature on the pump engages gears more quickly, so you'll have that steady flow as soon as you hit start. For example, what you would do is prime your central line on a sterile field, then you would place the syringe in the pump. Before connecting to your patient, you would then utilize your prime feature on the pump. This will reduce their startup delay. Therefore, when you start that infusion for the 1 ml an hour, the patient will be immediately seeing that rate. You can also notice that actual flow rate has small boluses and pauses, which again is related to the syringe pump mechanism. The faster the rate, the less pulsatile and more smooth the flow rate will be. Think of this like riding a bike. As you're starting off pedaling, it's not smooth and hard to get your balance. As you pedal faster, the ride is smoother, more consistent, and you feel more balanced. The FDA recognized that flow rate continuity is a challenge at low flow rates and has issued that safety communication back in 2016. They shared this communication with syringe pump manufacturers and asked them to share with customers as well as update labeling to inform users of flow continuity concerns. This was evident by the adverse events that were reported to the FDA. These adverse events included reports of unstable BP, anxiety from loss of sedation, increased pain indicators in critically ill infants with low flow rates. The FDA concluded the benefit of syringe pumps outweighs the risks, and users need to be aware of this information. Although the safety communication was back in 2016, it still applies to all syringe pumps today. The content and its recommendations remains relevant in practice because syringe pumping mechanisms still consist of the stepper motor and lead screw. Not all healthcare professionals who use or manage syringe pumps are aware of this information. Let's take a closer look at factors that influence startup delays and flow rate continuity. Manually priming on a sterile field, either at the bedside or in a dedicated area. Once your syringe and your tubing are fully primed, you would go to your pump, load your syringe, and when you get your pump prime feature in the setting of picking your care area and the drug, it is recommended by the manufacturer that you use this prime feature. You would do this prior to connecting to your patient, still over your sterile field. Once the pump has primed, you would then connect to your patient's line. Have you ever had an alarm or alert appear on the screen while programming an infusion that prevented the infusion from running? Let's talk about how this can happen and how it would affect your nursing flow. Some pumps have what we call minimum recommended flow rate and a minimum programmable flow rate. Both of these alerts are dependent on syringe size and rate. The minimum recommended flow rate is the rate at which you can expect to see minimum variability in flow. The minimum programmable flow rate is the lowest rate at which the syringe pump will run. The minimum recommended flow rate is especially important for continuous medications that are high alert, have a short half-life, and are vasoactive. all scenarios where you want that consistent flow rate. You may get an alert on your pump, but you are still able to infuse. This is where you can contact pharmacy if you're noticing a lot of these pop-up screens and try and optimize which syringe sizes are being sent to the bedside. Minimum programmable flow rate is the lowest rate at which a syringe pump will run. It will not infuse at these rates. How will this affect your practice? It'll delay an infusion because the pump will not accept the program rate and the nurse will not be able to start the infusion. The patient may have increased blood pressure, a drop in blood pressure, or an increase in agitation if you are running a sedation medication. Are there situations where you may need to infuse below the minimum recommended flow rate? The answer to that is absolutely. And when you would do that is continuous infusions of medications that are not high alert or vasoactive medications. Medications that are being titrated to effect or titrated off, and amount or volume over time infusions. Another type of alarm you may encounter is an occlusion alarm. Here's the reason why you may see this. You may see this with the type of viscosity of your medication, line type and size. Do you have a peripheral, umbilical, or another central line? Increased intravascular pressures. Is your patient crying, vomiting? Noting the patient's positioning as well. Number of infusions going through a single lumen and the rates of these infusions. Multiple infusions going through a 1 or a 1.2 French catheter can cause more of an occlusion than multiple going through a 2 French catheter. Your syringe size, if you have selected the wrong brand or size, and ensuring the syringe barrel and plunger are firmly engaged in the pump's mechanism. And lastly is your line connection, ensuring that you have full connection between all of your drips to your patient's line. Let's take a couple minutes to consider occlusion alarms. During the drug library configuration, pharmacy will work with nursing education on deciding the pressure settings, weighing the risk versus benefits of frequent alarms versus interruption of flow. The FDA safety communication that I previously mentioned addresses occlusion alarms and states that the goal is to decrease the time to trigger an occlusion alarm. One way to do this is to use low pressure settings. However, using low pressure settings does need to be balanced with decisions regarding properties of the infusion. For example, if you're infusing a thick fluid like enteral nutrition or lipids, you may want to have a higher pressure setting. Decreasing the time to occlusion can be accomplished by getting the drug or the fluid to the patient quicker, which is done by using small syringes and by priming on the pump. You should use accessory devices with the smallest internal volume, which is also known as your dead space. This minimizes residual volumes between the syringe and the patient at low flow rates. You can accomplish this by using small bore microbore tubing, shorter tubing length, and minimizing dead space of inline filters. Considerations for patients receiving multiple infusions. You really want to make sure you're prioritizing the placement of your critical medications. Critical medications with a shorter half-life should be placed closest to the patient to avoid the microboluses from other infusions, as well as minimizing their dead space. Carrier fluids should be positioned farthest away from the patient to maintain consistent flow rate and reduce the impact of the flow rate changes over the other medications. Minimizing the amount of infusions when possible going through a single lumen to prevent microboluses when the variation of flow rates and intermittent medications. Understanding that this isn't always possible depending on your access. In this photo here, we have your more critical drips to be displayed in the front with your carrier fluids in the back to prevent those microboluses. Here are some unique considerations. Specifically in the NICU, your baby will be in an isolette. With the isolette, you want your critical meds at heart level with the syringe. In this photo, you can see a parent holding a baby. You can see the syringe pump is set to the correct level when the patient is laying in the bed. However, when being held, you can see that the patient is well below the pump. This is something to consider when you have critically ill patients on multiple infusions and they're being held by the parent. You can see an increase in occlusion alarms, potentially needing to increase your boluses, considering bringing those pumps lower to the patient's heart level here, whether it's on a table, lowering on the pole. Bringing that to the correct height will ensure the accuracy of your flow rate. Key takeaways from today's presentation are considering the placement of the syringe pump relevant to your patient, assessing which medications will be infusing and how many lumens you have, selecting the appropriate brand and size of syringe for that flow rate, minimizing your mechanical slack, standardizing syringe changeover practices, and understanding the impact of your accessory devices. Also, understanding each alarm that your pump is having.
Thanks so much, Jenny. One question we have is, how can you foster a better pharmacy nursing partnership for some of these things pertaining to flow rate? That partnership is so important because the pump is managed by pharmacy, and some of these things pertain to pump configurations and alarms. So having that open line of communication with nursing and even anesthesia as the end user is really important to be sure that the rationale behind some of those settings is understood and balancing the safety, but also not hindering practice too much. And then anything you want to add, Jenny?
Yeah, I agree with Sammy. And then also just having that communication with nursing. So they know they can go to pharmacy, because I think as a nurse, that is hard to figure out, like who from pharmacy would be your contact. So streamlining that, whether it's bringing it to your nurse manager who is in direct contact with the pharmacist, would be the best way.
Thanks, Jenny. And just a reminder, the QR code on the screen now is the survey for the webinar. So if you want to take a screenshot of that now, please, and thank you for completing that. Another question in the chat is just want the link to the recording because they missed a little bit in the beginning. So this recording will be posted to our medical affairs news to infuse website. It usually takes 1 to 2 weeks before we can post it there. And Jenny, if you go forward one slide, I think there is a QR code. Yes, this is the QR code to the news to infuse website. If you missed part 1, like I said in the beginning, that is also posted there, which pertains to the dispensing piece of this talk. Another question for you, Jenny. With your previous experience at the bedside and now coming to Baxter with much more of a focus on the syringe pump mechanism, was there anything really surprising to you that you didn't know before that you are now incorporating to your practice at the bedside?
So the big thing for me is the mechanical slack and understanding that. At the bedside, we didn't know anything about the mechanical slack. So I thought when you put your syringe on your syringe pump and you hit run, your dopamine, your fentanyl was infusing at the programmed rate. You would notice delays where your patient was taking longer to show sedation signs or taking longer for the blood pressure to start titrating to effect. So for me, the biggest thing is understanding that mechanical slack and really making sure that nurses understand that priming on the pump will help that the patient outcome as well as the nurse from having to titrate up and then back down quickly.
Awesome. Thank you, Jenny. Another question, being a flight nurse, have you seen impact of infusion flow rate when in the helicopter plane? Can you speak to the impact of the flow rate with different infusion devices when in the air?
The mobile environment, you tend to need higher rates, and a lot of that is your external factors, whether it's the bumps on the road, the turbulence in the helicopter. So really adjusting to what your patient's needs are, where you may pick them up at a level 4 NICU or high level PICU, expect to have to be on higher rates in the back of the truck or in the helicopter, and knowing when you do hand off that they'll likely titrate down quickly. So it's just adjusting to patient's effect. And some patients are a lot more sensitive to the moving environment than others. So it's paying attention to the subtle movements, subtle changes in blood pressure, heart rate, and agitation.
Thanks, Jenny. Yeah, definitely a unique environment. One other question was if the slides will be shared. So the slides will be part of the recording that gets posted to News to and Views. I don't think we have any other questions. So thank you all for joining today. We really appreciate you hopping on and also appreciate you filling out the survey. And this recording will be posted to the website in a few weeks.